Like away from the house, like.
All right, settle down. Take your seats.
What's up, dude? You remember me? Yeah, you're the judge. Did I wear the same thing I was wearing?
What is this?
Ladies and gentlemen,
Are you here to talk about drugs again?
I'm going to talk to you about the adverse effects of antipsychotic medications. The use of antipsychotic medications entails a difficult trade-off between the benefit of alleviating psychotic symptoms and the risk of troubling, sometimes life-shortening adverse effects. There is more variability among specific antipsychotic medications than there is between first and second generation antipsychotic classes. The newer second generation antipsychotics, especially clozapine and olanzapine, generally tend to cause more problems relating to metabolic syndrome such as obesity, type 2 diabetes, mellitus. Also as a class, the older first generation antipsychotics are more likely to be associated with movement disorders, but this is primarily true of medications that bind tightly to dopaminergic neuroreceptors, such as haloperidol, and less true of medications that bind weakly, such as chlorpromazine. Cholinergic effects are especially prominent with weaker binding first generation antipsychotics, as well as the second generation antipsychotic clozapine. All antipsychotic medications are associated with an increased likelihood of sedation, sexual dysfunction, postural hypertension, cardiac arrhythmia, and sudden cardiac death. Primary care physicians should understand that the individual adverse effect profiles of these medications. They should be vigilant for the occurrence of adverse effects, be willing to adjust or change medications if needed, or work with psychiatric colleagues to do so, and be prepared to treat any resulting medical sequelae. Antipsychotic medications effectively diminish the intensity of psychotic hallucinations, allowing most institutionalized patients with schizophrenia to be discharged into community treatment. The first generation antipsychotics, also known as FDAs, work through dopamine D2 neuroreceptor blockade, and a subsequent series of new antipsychotics were developed with stronger dopamine blockade. To discuss differences in the adverse effect profiles of FDAs, we use the terms low potency and high potency, not to indicate their clinical effectiveness, but rather to indicate their potency in binding to the dopamine D2 neuroreceptor. Table 1 outlines selected FDAs. We will go over Table 1 later. The usual maintenance dosage and relative potency of dopamine D2 neuroreceptor blockade. We will not go over Table 1. Chlorpromazine, the usual daily maintenance dosage is 400 milligrams. The dopamine D2 neuroreceptor potency is low. Thorazine, 200 to 300 milligrams is the daily maintenance dosage, and it is low in the dopamine D2 neuroreceptor potency. Perfenazine, 24 milligrams, medium. Fluphenazine, 10 to 20 milligrams, high, very high potency, Thiofixine, 30 milligrams, high potency. Trifluropro, 20 milligrams, high. Second generation antipsychotic SPAs were launched in 1989 when investigators found that clozapine, clozaril, was more effective than chlorpromazine with fewer extrapyramidal symptoms. These new antipsychotics were considered atypical because they targeted neuroreceptors other than only dopamine. Over the past 2 decades, SGAs have dominated prescribing preferences in the United States under the assumption that they are more effective and safer than the FDAs. Table 2 lists SGAs marketed in the United States, the year in which each was introduced, and the usual daily dosage. So we won't go on to Table 2. Results of 2 recent publicly funded studies designed to evaluate the effectiveness of these treatments under real-world conditions have called into question these prescribing preferences. The clinical antipsychotic trials of intervention effectiveness study was designed to compare the FGA perfenazine with several SGAs, using all-cause discontinuation as a proxy measure for effectiveness. The cost utility of the latest antipsychotic drugs in schizophrenia study measured quality of life and other effectiveness measures. Leave. Now, leave. Get out of the room. Leave. Leave. Like, use your feet. Leave. I'll summon you. Leave. 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 Leave.
Summon me.
Leave. Leave.
Leave.
Use your feet. Go. You're not missing anything. Go.
Just me doing. Most of us don't even understand what you're doing. Yeah, what are you saying?
Sedation. Sedation is common with antipsychotic medications and is dose-related. It can be a cause of poor compliance, and if persistent, can interfere with social and vocational functioning. Many patients become tolerant to the sedative effect over time. Low-potency FDAs and clozapine are the most sedating, with some effect from olanzapine, Zyprexa, and quetiapine, Seroquel. Somnolence can be alleviated by lowering the dosage, changing to a single bedtime dose, or switching to a less sedating medication. Hypertension, orthostatic hypertension, can occur with all antipsychotic medications depending on the degree of A1 adrenal receptor antagonism, but particularly with low-potency FDAs and clozapine. It can also occur with risperidone, and quetiapine, especially with rapid titration. This effect is more common in older adults with risk of falls, those on blood pressure medications, and those who have other cardiovascular diseases. With careful dose titration, patients may become tolerant to this effect. Treatment options include decreasing or dividing doses or switching to a medication with lesser anti-adrenic effect. Anticholinergic effects. Anticholinergic effects include constipation, urinary retention, dry mouth, blurred vision, and at times cognitive impairment, like this kid. These symptoms lead to other problems such as tooth decay, falls, or gastrointestinal obstruction. Low-potency FDAs and clozapine are highly likely to cause anticholinergic effects. Olanzapine and quetiapine have been shown to do so at high dosages when needed, and doses can be lowered or divided to help alleviate this problem. Antipsychotic medications can cause four main extrapyramidal symptoms: pseudoparkinsonism, akathisia, acute dystonia, and tardive dyskinesia. The first three usually begin within a few weeks of starting a new medication or increasing the dosage. These symptoms may cause discomfort, social stigma, and poor compliance. They are more likely to occur with higher dosages of high-potency FDAs, such as haloperidol, formerly Haldol, and are less likely with FDAs that have shown that FDAs are less likely to cause extrapyramidal symptoms. However, recent studies comparing SGAs with lower potency FDAs have not shown this difference. Pseudoparkinsonism is a reversible symptom that includes tremulousness in the hands and arms, rigidity in the arms and shoulders, bradykinesia, akinesia, hypersalivation, masked faces, and shuffling gait. The presence of bradykinesia or akinesia can create a diagnostic dilemma with symptoms resembling depression or even the negative symptoms of schizophrenia. For example, an inability to pay attention, the loss of the sense of pleasure, the loss of will to drive, disorganization or impoverishment of thoughts and speech, flattening of affect, and social withdrawal. Treatment options include dosage reduction or the addition of oral anticholinergic agents. Examples are benztropine, diphenhydramine, and that physicians should keep in mind that these medications can cause their own adverse effects. Akathisia is described subjectively as a feeling of inner restlessness that can be manifested as excessive pacing or inability to remain still for any length of time. It can be difficult to differentiate akathisia from psychiatric anxiety and agitation. Treatment of akathisia can include a dosage reduction when possible, or the addition of a low-dose beta blocker such as propranolol, Inerdol, at 20 to 80 milligrams per day. Dystonic reactions are spastic contractions of the muscles, including oculargic crises, retrocollis, torticollis, trismus, opisthonos, or laryngospasms. These reactions are uncomfortable and can be life-threatening if left untreated. Intervention often requires administration of intravenous or intramuscular allocholinergic effects. Tardive dyskinesia is an involuntary movement disorder that can occur with long-term antipsychotic treatment and may not be reversible even if the medication is discontinued. Tardive dyskinesia usually involves the orofacial region, but all parts of the body can be involved. Abnormal movements include myoclonic jerks, exchoria, and dystonia. They become most evident when patients are aroused but ease during relaxation and disappear during sleep. Risk factors develop tardive dyskinesia, including long-term therapy with FDAs at higher dosages, older age, female sex, and concurrent affective disorders. Attempts to treat tardive dyskinesia usually begin by continuing the offending agent or switching to one with a lower risk, but evidence is sufficient to show that this or any other treatment markedly reduces symptoms after onset. Hyperprolactinemia. Antipsychotics cause prolactin levels by blocking the normal tonic inhibition on pituitary mammotrophic cells of dopamine produced in the hypothalamus. Hyperprolactinemia is common with any use of FGA, as well as the SGA risperidone, up to 60% of women and 40% of men, and is dose-dependent. It appears to be much less common with other SGAs, but has been reported with the use of olanzapine and ziprasidone, Giodon, at higher dosages. Hyperprolactinemia can be asymptomatic, but may cause gynecomastia, galactorrhea, oligoamenorrhea, sexual dysfunction, acne, hirsutism, infertility, and loss of bone mineral density. Symptoms often appear within a few weeks of beginning the antipsychotic or increasing the dosage, but can also arise after long-term stable use. There is growing evidence that chronic hyperprolactinemia from antipsychotics can cause osteoporosis and an increased risk of hip fracture. A recent case control analysis of a large general practice database in the United Kingdom shows that the risk of hip fracture was 2.6 times higher in patients taking prolactin-raising antipsychotics compared with the general population. Physicians should routinely inquire about symptoms that might reflect prolactinemia in patients taking prolactin-raising antipsychotics, and if present, measure the serum prolactin level. Presence of osteoporosis, sexual side effects, or prolactin-dependent breast cancer may necessitate switching to an antipsychotic that does not raise prolactin levels, such as risperidol, Abilify, or quetiapine. Sexual dysfunction. Up to 43% of patients taking antipsychotic medications report problems with sexual dysfunction and distressing adverse effects that can lead to poor medication adherence. Due to antipsychotics, or use of antipsychotics can affect all phases of sexual function. Both FGAs and SGAs can impair arousal in men and women. FGAs especially have been found to cause dysfunction in men, including spontaneous and painful, as well as priapism, and granulocytosis in rare cases. Possibly may cause neutropenia in less than 1,500 cells per millimeter squared. Cardiac arrhythmias. All antipsychotics can contribute to prolongation of ventricular repolarization prolonged QT interval, which can in turn lead to tostatus de pointis and sudden cardiac death. This effect is most marked with the low-potency FGA thioredoxine and SGA ziprasidone and is dose-dependent. The incidence of sudden cardiac death among patients taking antipsychotics is about twice that of the general population.
You have a question?
No.
Yeah, what was
Stephen
the...
Johnson.
Stephen Johnson.